Hey, welcome to the briefing. What I'm going to cover with you today is this. Before you close the chart, inspect the result loop. I want to take this one into healthcare because healthcare is one of those environments where activity can look a lot like completion. That is a dangerous thing. The chart has movement. The inbox has activity. The result has been reviewed, the task has been routed, the patient got a portal message, the nurse left a voicemail, the provider added a note, the follow-up was mentioned somewhere. The EHR shows that people touch the work. From a distance, it can look handled, but handled is not the same as closed. That distinction matters in healthcare because a result loop does not close just because something happened in the chart. It closes when the next required action is clear, owned, communicated, tracked, and completed or deliberately escalated. A lab result can be viewed but not acted on. It can be acted on but not communicated. It can be communicated but not understood. It can be routed but not owned. It can be flagged but not followed. It can be documented but not completed. Under pressure, the open loop can hide inside normal chart activity. That is what makes this problem so dangerous. It does not always look dramatic at first. It does not always look like a major breakdown. It can look like a normal day in a busy clinic. Patients are being roomed. Phones are ringing. Results are posting. Providers are reviewing. Nurses are calling. Medical assistants are moving. Front desk staff are scheduling. Referral coordinators are working. Everybody is busy, but busy does not mean closed. I have seen enough leadership problems across different environments to respect this now. A process can be loud with activity and still be weak at the point of ownership. That is one of the mistakes leaders make when they are trying to read from too far away. They see motion and assume control. They see documentation and assume completion. They see a task moving and assume responsibility is clear. Sometimes it is. A lot of times it is not. In healthcare, that gap can carry real patient safety risk. Now let me be clear at the front. This is not about excusing poor follow-through. If a provider ignores a result, that matters. If a nurse closes a task without doing the required action, that matters. If a medical assistant misses a scheduling step, that matters. If documentation is weak, that matters. Accountability does not disappear because the workflow is complicated, but accountability has to be aimed correctly. If a leader only asks, who touched the chart last? The read may be too narrow. If a leader only asks, who forgot to call the patient? The read may be too narrow. If a leader only asks, who closed the task? The read may be too narrow. Those questions may matter, but they are not enough by themselves. The stronger question is this: where exactly did the result loop lose ownership? That is where close-up analysis matters. Close-up analysis is the discipline of getting close enough to inspect the exact part of the workflow where friction, delay, ambiguity, handoff failure, or risk is forming. In this case, we are not looking at the whole clinic. We are not blaming the whole team. We are not giving another generic reminder to communicate better. We are inspecting the result loop, the result posts, the provider reviews. The urgency is interpreted. The next action is written. The task is routed. The patient is contacted. The portal message is sent. The voicemail is left. The follow-up order is placed. The repeat test is scheduled. The referral is moved. The patient understands what to do. The loop is either closed, tracked, or escalated. That is the sequence. Somewhere inside that sequence, ownership can break. The mistake is treating that break like one careless click before you inspect where the ambiguity entered. Think about a busy outpatient primary care clinic connected to a larger health system. We will call the practice manager Jordan. Jordan is responsible for a clinic that sees adults with diabetes, hypertension, kidney disease, respiratory concerns, medication changes, preventive care needs, and chronic disease follow-up. The schedule is full most days. The inbox never really feels empty. The provider team is moving from visit to visit. Nurses are covering triage and callbacks. Medical assistants are rooming patients, handling tasks, and supporting provider flow. A referral coordinator is trying to move specialist orders. The front desk is dealing with scheduling, patient questions, insurance friction, and late arrivals. That clinic may have good people. It may have committed people. It may have people who care deeply about patients, and still the result loop can fail. That is the part leaders have to be mature enough to hold. A good team can still have a weak loop. A strong provider can still leave an unclear next action. A careful nurse can still be put inside a workflow where the second contact attempt is not owned. A medical assistant can still miss a scheduling step if the task does not make the next action clear. A patient can still be confused even when the clinic believes the message was sent. Over the last month, Jordan sees several follow-up concerns surface. A patient did not schedule a repeat lab. Another patient did not understand that a medication change was needed. A referral was ordered but not completed. A nurse left a voicemail, but no second attempt was tracked. A provider note said follow up in 2 weeks, but the appointment was never made. No single failure looked dramatic. That is what made the pattern easy to underestimate. No one threw the chart away. No one refused to do their job. No one said the patient did not matter. The result pathway just had enough small gaps that the loop could look active while the patient still did not have the next action completed. That is where healthcare gets difficult. The system can show motion while the patient experiences confusion. The chart can show activity while ownership is unclear. The clinic can feel busy while the loop remains open. The newest issue involves an abnormal lab result for a patient with chronic disease risk. The result is not labeled as a life-threatening critical value, but it does require timely follow-up. The provider reviews the result late in the day. A note is added. A task is sent to nursing. A portal message is generated. The nurse attempts a call. The patient does not answer. A voicemail is left. A follow-up lab is recommended. The chart shows activity. Then 2 weeks later, the patient calls and says they did not know they needed another test. Now the clinic has a problem, and the first fix can feel obvious. Coach the nurse. Remind the provider. Tell the team to close tasks. Review documentation expectations. Tell everyone to communicate better. Tell everyone to follow protocol. Each part of that may be reasonable, but it may not be enough, because the real issue may not be only that someone failed to follow up. The issue may be that the workflow treated the first contact attempt like meaningful progress, but never defined what happened next when contact failed. That small detail matters. A voicemail is not patient understanding. A portal message is not patient understanding. A provider note is not task ownership. A recommendation is not a scheduled lab. A referral order is not a completed referral. A chart comment is not closed loop follow-up. If those distinctions are not clear, the clinic may think the loop is moving while the patient is still sitting outside the action. That is the leadership trap. The trap is treating a missed result like a simple attention problem. Someone should have called. Someone should have documented. Someone should have noticed. Someone should have followed up. Someone should have closed the task correctly. Maybe. But the leader has to get closer before deciding that is the whole problem. The result may have traveled through a workflow that was never clean. The provider may not know which abnormal results require direct call versus portal message. The nurse may not know whether the provider already spoke with the patient. The medical assistant may receive a task without clear urgency. The patient may not understand the portal note. The callback may be documented in one place while the follow-up order sits somewhere else. The lab result may be acknowledged without a clear next action. The chart may look active while the patient is still waiting. That is not one problem. That is a stack. Stacked failures do not always show up as stacked failures. Sometimes they show up as one missed follow-up. That is why close-up analysis changes the read. Instead of asking, who messed this up, Jordan starts asking, where exactly did the result stop being owned? Was it when the provider wrote the note? Was it when the task was routed? Was it when the nurse left the voicemail? Was it when the task remained open without a second attempt owner? Was it when the repeat lab was recommended but not scheduled? Was it when the portal message used clinical language the patient did not understand? Was it when no one confirmed patient understanding? Was it when the follow-up order sat in a different part of the system than the patient contact note? That is the level of inspection this requires. Not because Jordan wants to micromanage the team, because patient safety risk often hides at the exact point where ownership changes hands. A provider thinks nursing owns the call. Nursing thinks the provider's note gave the instruction. The medical assistant thinks the portal message closed the communication piece. The referral coordinator thinks scheduling owns the next step. The patient thinks the clinic will call if something is urgent. The EHR shows enough activity that no one feels the full weight of the open loop until the patient calls back confused. That is a bad place to discover the gap. Now think about what happens if Jordan fixes this from too far away. He sends a staff-wide reminder, document better, close tasks properly, make sure patients understand results, and communicate clearly. That sounds responsible. It may even help for a few days. People become more careful. Nurses leave more detailed notes. Providers write a little more. Medical assistants hesitate before closing tasks. The team pays attention because the miss is fresh. But if the loop itself is still unclear, the same risk comes back. Providers may still write short notes that require interpretation. Nurses may still treat voicemail as partial completion without a next step. Medical assistants may still be unsure whether they own scheduling. Patients may still receive portal messages that do not say in plain language what they need to do next. Referral orders may still sit without confirmation. Tasks may still close before the required action is actually complete. The clinic may still depend on memory, habit, and individual judgment instead of a clear result loop. That is the cost of fixing from too far away. You get temporary attention. You do not get durable control. In healthcare, temporary attention is not enough when the loop can carry patient safety risk. A broad reminder may make everyone alert for a short window, but alertness fades when the schedule fills, the inbox backs up, the phone rings, and the next abnormal result lands in the system. If the workflow still depends on people remembering what the leader said last week, the loop is still weaker than it should be. So Jordan gets closer. He looks at the abnormal result pathway from the staff side and the patient side. That matters because the chart side and the patient side are not always the same reality. On the chart side, there may be a note, a message, a task, and a call attempt. On the patient side, there may be confusion, no answer, no understanding, no appointment, no repeat test, and no clear sense of urgency. Those are two different views of the same loop. The leader has to see both. Jordan starts with result arrival. When the result posts, where does it go? Does it go to the provider inbox? Does it get flagged by urgency? Does the system distinguish critical, abnormal, non-critical, abnormal, routine, and informational? Does the result display in a way that helps the provider understand what must happen next? Or does everything just become another item in the inbox? That matters because not every abnormal result carries the same risk. But every result still needs a clear pathway. If urgency is not clear, the next action can become inconsistent before anyone even touches the patient. Then Jordan looks at provider review. When the provider reviews the result, does review mean I saw it, or does review mean I defined the next action? Those are not the same. A provider can see the result, understand the clinical concern, and still leave the next operational step too vague for the team. That is not always neglect. Sometimes it is a translation gap between clinical judgment and workflow execution. The provider knows what should happen. The team needs that next action stated clearly enough to execute. Then Jordan inspects next action language. Is the instruction specific? Does it say call patient today, repeat lab in 2 weeks, schedule follow-up visit, change medication, refer to specialist, monitor symptoms, or go to emergency care if symptoms worsen? Or does it say something like, follow-up needed, and leave the rest for interpretation? Interpretation is where variation enters. One nurse reads that as direct call. Another reads it as portal message. Another waits for provider clarification. Another documents an attempt but does not know what to do if the patient does not answer. Then Jordan looks at task routing. Who receives the task? Nursing, medical assistant, care coordinator, front desk, a general pool. Does the task have urgency? Does it have a due date? Does it have a named owner? Does it identify what closure means? Or does it just land in a pool where everyone can see it but no one has full ownership? That is a classic failure point. A task visible to many people can still be owned by nobody. Visibility is not ownership. Access is not accountability. A pool is not a person. Then Jordan inspects patient contact. Was the patient called? Did the patient answer? If not, was voicemail left? Was the voicemail specific enough without violating privacy? Was a portal message sent? Did the patient actually open it? Did they understand it? If the patient did not answer and did not read the portal message, what happens next? This is where many loops weaken. The first contact attempt becomes progress. Progress starts feeling like closure, but progress is not closure. Then Jordan inspects order placement. If a repeat lab is recommended, is it actually ordered? If a referral is recommended, is the referral order placed? If a medication change is required, is the prescription updated? If follow-up is needed, is the appointment scheduled? If the next action depends on the patient, is there a mechanism to check whether the patient completed it? A recommendation without an ownership path is not enough. The chart can say what should happen, but the patient still needs a pathway into the action. Then Jordan inspects scheduling. Who owns moving the patient from recommendation to appointment? Is that the nurse, medical assistant, front desk, provider, patient, referral coordinator? If the patient needs a repeat test, does the clinic schedule it, instruct the patient to schedule it, or simply note that it should happen? If the answer depends on who touched the chart, the loop is weak. The clinic cannot rely on each person's private interpretation of the workflow when the result requires timely follow-up. Then Jordan inspects documentation. Where is patient contact documented? In the phone note, in the task, in the result note, in the patient message, in the referral record? If staff document in different places, the chart may technically contain the information, but the next person may not see it when they need it. That matters. Documentation that exists but cannot be found at the decision point is not as useful as leaders think it is. In a high-volume clinic, documentation has to support the next action, not just prove that someone typed something somewhere. Then Jordan inspects escalation. What happens when the patient cannot be reached? 1 attempt, 2 attempts, portal plus phone, letter, escalation to provider, certified letter for high-risk results. Different clinics handle this differently depending on policy, result type, and risk. But the ownership has to be clear. If no contact abnormal results have no defined escalation path, the clinic is relying on individual judgment inside a high-volume system that is not safe enough. Then Jordan inspects closure. This is the key. What does closed mean? Does closed mean someone reviewed the result? Does closed mean someone attempted contact? Does closed mean the patient was reached? Does closed mean the patient understood? Does closed mean the order was placed? Does closed mean the repeat lab was scheduled? Does closed mean the repeat lab was completed? Does closed mean the provider was notified that the patient could not be reached? If the clinic cannot answer what closure means, then task closure becomes dangerous because the task may close before the loop is actually closed. That is the kind of detail close-up analysis is built to reveal. And now I want to bring this into the human side because this is not just boxes and tasks and workflows. There are people carrying this. The provider is under pressure. They may be reviewing results between visits, after clinic hours, or at the end of a long day. They may be trying to make clinically sound decisions while the inbox keeps filling. Their note may make perfect sense to them because they understand the patient, the diagnosis, the risk, and the next step. But the team needs operational clarity, not just clinical understanding. And the nurse is under pressure. They may be covering triage, patient calls, medication questions, portal messages, urgent complaints, and multiple provider tasks. When a result task comes in, they need to know the urgency, the required message, the fallback if the patient does not answer, and whether they own follow-up after the first attempt. Without that, They are forced to interpret the loop while the rest of the clinic keeps moving. The medical assistant is under pressure. They may be rooming patients, handling refills, preparing charts, managing tasks, helping with procedures, and supporting the provider. If they get pulled into follow-up scheduling or patient messaging, they need to know exactly what they are allowed to do and what needs to go back to the provider or nurse. Ambiguous tasking does not make them more flexible. It makes the loop more fragile. The front desk is under pressure. They may get a patient call after a portal message and have no clinical authority to answer the question. If the message says your result requires follow-up, the patient may call the front desk asking what that means. If the front desk does not have a clear routing path, the patient gets delayed again. The patient may think the clinic is passing them around. The staff may think they are following the system. Both can be true. The referral coordinator is under pressure too. A referral order can exist, but that does not mean the specialist appointment is scheduled. The referral may need records, insurance authorization, patient contact, specialist acceptance, or follow-up if the specialist does not respond. If the abnormal result depends on referral completion, then referral movement becomes part of the result loop. The loop is not closed just because the referral order exists. The patient is under pressure too. That matters. Patients do not live inside the clinic's workflow. They may work during clinic hours. They may miss calls. They may not check portal messages. They may read a result and not understand the significance. They may see abnormal and panic. They may see a technical explanation and assume it is routine. They may not know whether they are supposed to call, wait, schedule, change medication, repeat a lab, or go somewhere else. So when the clinic says, we sent the portal message, the patient may still be sitting there unclear, and unclear is not closed. That is why patient-facing communication deserves inspection. Compare what the chart says to what the patient receives. The chart may say, repeat basic metabolic panel in 2 weeks due to abnormal renal function indicators. The patient may read that and not know what basic metabolic panel means, why 2 weeks matters, whether they need to schedule it, whether someone will call them, or whether the abnormal result means danger right now. The leader has to ask, can the patient understand the next action without translating clinical language? Not can a clinician understand it. Can the patient understand what they need to do next? That is the point. A portal message can be accurate and still fail operationally. A voicemail can be polite and still fail to create action. A task can be routed and still fail to create ownership. A note can be documented and still fail to close the loop. This is why broad coaching is not enough. Communicate better does not tell the provider how to write the next action note. Document better does not define where the contact attempt belongs. Follow up faster does not define who owns the second attempt. Close your tasks does not define what closure means. Be careful does not fix a weak result pathway. Those reminders may be well intended, but they are too broad to carry the work. Close-up analysis forces the leader to name the specific detail. If the problem is unclear provider notes, fix the note structure. If the problem is weak task routing, fix the routing rule. If the problem is failed contact ownership, define the second attempt. If the problem is patient understanding, rewrite the patient-facing language. If the problem is follow-up scheduling, assign ownership to the scheduling step. If the problem is referral completion, track referral movement until it reaches a real next action. If the problem is task closure, define what closed means. That is leadership, not blame, not softness, not bureaucracy. Operating discipline. Now I want to be careful about something. Healthcare leaders do not need to turn every abnormal result into a full investigation. That is not practical. That would drown the clinic. Close-up analysis does not mean every task gets treated like a major incident. It means when a pattern appears, or when a patient safety concern surfaces, or when the same type of loop keeps showing weakness, you do not fix from a distance. You inspect the failure point. That inspection can be quick. Take one result loop and walk it from result arrival to closure. Ask what happened at each step. Ask who owned the next action. Ask where the patient received direction. Ask where the loop depended on memory. Ask what happened when the patient did not answer. Ask whether the recommended action became a scheduled action. Ask whether the task closed before the loop closed. That kind of inspection can reveal more than another staff-wide reminder ever will. The reason this matters is that healthcare teams already carry enough pressure. If leadership blames from too far away, staff feel the unfairness immediately. They know the workflow is messy. They know the EHR has too many places to document. They know the patient portal does not always equal patient understanding. They know tasks can sit in pools. They know urgent and non-urgent work can blur together when volume is high. They know some instructions are clear and some require guessing. When leadership ignores all of that and says you need to do better, the team may comply on the surface while trust erodes underneath. But when a leader says we are going to inspect where this loop lost ownership, that feels different. It does not remove accountability. It makes accountability more accurate. That is the standard. A leader can still hold people responsible, but the leader is now holding them responsible at the right point in the sequence. This is where the field level question matters. What exact moment needs correction? Not what department is bad, not who is careless, not why is everyone overwhelmed. The exact moment, result review, urgency classification, next action note, task routing, patient call, voicemail follow-up, portal message clarity, order placement, scheduling, referral movement, documentation location, escalation, closure. Pick the moment where the loop weakened. Then separate human error from workflow ambiguity. Did someone ignore a task or was the task unclear? Did someone close a loop too early or did the workflow fail to define what closure means? Did the patient miss the instruction or did the instruction fail to make the next action clear? Did the referral stall because someone dropped it or because no one owned the movement after the order was placed? Do not protect poor follow-through. Do not hide workflow ambiguity behind human error. Separate them and then check the ownership point. Who owns the result after provider review? Who owns the patient call? Who owns the second attempt? Who owns scheduling? Who owns referral follow-up? Who owns escalation if the patient cannot be reached? Who owns confirming that the recommended next action actually happened? Many result loop failures worsen at the ownership point. The handoff is where the loop gets fragile. The result moves from clinical review to operational follow-through, and if that handoff is weak, everybody may believe the work is moving, while nobody owns the full closure. Then inspect the patient-facing communication. Does the message tell the patient what happened? Does it tell them what to do? Does it tell them when to do it? Does it tell them who will contact whom? Does it tell them what symptoms or changes should trigger immediate action? Does it use plain language? Does it avoid making the patient interpret clinical terms? If patient-facing communication is weak, the clinic may think the result was communicated while the patient still does not know the next step. Then decide what needs correction. The answer may be coaching. It may be result routing logic. It may be provider note structure. It may be voicemail follow-up rules. It may be clearer task ownership. It may be escalation timing. It may be a result loop checklist. It may be a standard for plain language portal messages. It may be a defined rule that voicemail does not close certain abnormal result tasks. It may be a rule that repeat labs are scheduled before the loop is marked complete. It may be a review of where documentation belongs so the next person can find it. Close-up analysis does not slow healthcare leaders down for no reason. It helps them correct the right detail. Now let's talk about what leaders should watch for. Watch for task closing before the action is complete. If task closure only means someone touched the chart, the clinic may be mistaking activity for completion. Watch for voicemail being treated like communication. A voicemail attempt matters, but it is not the same as confirmed patient understanding. Watch for providers writing notes that require interpretation. If staff have to guess the next action, variation enters the result loop. Watch for patient messages that are clinically accurate but operationally unclear. A patient can receive a result and still not know whether to call, schedule, wait, repeat a lab, change medication, or monitor symptoms. Watch for second attempts with no owner. Many loops fail after the first call attempt. No contact results need defined ownership. Watch for follow-up orders that are recommended but not scheduled. A recommendation is not a completed next step. Watch for referrals that exist as orders but are not tracked to action. A referral order is not the same as a completed specialist connection. Watch for documentation split across too many places. If the information exists, but the next person cannot find it at the moment of action, the loop is still weak. Watch for staff using different definitions of closed. That may be the biggest one. If closure means different things to different people, patient safety risk can hide in plain sight. This matters because healthcare leaders operate where communication, documentation, workflow, technology, and patient safety meet. That is why the work is difficult. The provider wants clinical accuracy. The nurse wants safe follow-up. The medical assistant wants clear task direction. The care coordinator wants clean referral movement. The front desk wants to route the patient correctly. The patient wants to understand what the result means. The clinic wants reliable closure. Those pressures all meet inside the result loop. If leaders only inspect the surface, they overcorrect the person and undercorrect the workflow. That weakens safety. Staff feel blamed, patients feel confused. Providers lose confidence in the follow-up process. Nurses carry unclear ownership. The clinic depends on memory instead of operating discipline. And memory is not enough when volume is high, tasks are moving, and patient risk is involved. Close-up analysis matters because healthcare problems often hide in small details. One unclear note, one weak handoff, one missed second attempt, one vague portal message, one task closed too early, one result routed without ownership, one follow-up order never scheduled. Those details are not small when they can affect patient safety, so before you close the chart, inspect the result loop. Ask what looks complete because the system shows activity. Ask what is actually complete because the patient has the next action. Ask whether the loop has an owner. Ask whether the patient understands. Ask whether the follow-up exists as an instruction or as a scheduled action. Ask whether the task is closed because the work is done or because someone touched their part. That question will make the read sharper, and it may prevent the leader from turning a result loop failure into a generic staff lecture. Let me bring this back to Jordan one more time. Jordan does not need to humiliate the nurse. He does not need to accuse the provider. He does not need to blame the medical assistant. He does not need to tell the entire clinic that everyone is failing. He needs to inspect the loop. He can say, we had an abnormal result that showed chart activity, but the patient did not complete the next action. We need to identify where the loop lost ownership. That is direct. That is fair. That is serious. Then he can walk the sequence. Result posted. Provider reviewed. Task sent. Patient called. Voicemail left. Portal message sent. Repeat lab recommended. Task left open or closed. No second attempt owner. No confirmation that the lab was scheduled. Patient called 2 weeks later confused. Now the correction is clearer. Maybe the clinic decides that certain abnormal results require a clearly written next action line from the provider. Maybe the task must include urgency, patient instruction, and closure criteria. Maybe voicemail creates a follow-up state, not closure. Maybe second attempts are assigned before the task can be closed. Maybe portal messages must include plain language action steps. Maybe repeat labs must be ordered and scheduled before the result loop is marked complete. Maybe no contact abnormal results escalate after a defined time. Those are real corrections. Specific corrections, corrections aimed at the failure point. That is the difference between leadership and reaction. Reaction says, pay closer attention. Leadership says, this loop loses ownership after the first failed contact attempt, and that is what we are correcting. Reaction says, document better. Leadership says, patient contact will be documented in this location, and task closure will require one of these outcomes. Reaction says, communicate better. Leadership says, portal messages for abnormal results will include plain language next action, timing, and who owns scheduling. Reaction says, do not let this happen again. Leadership says, here is the exact point where it happened, and here is the control we are putting in place. That is the standard. The result matters. The patient matters. The provider review matters. The nurse call matters. The documentation matters. But the result loop is where all of those pressures connect. If the same follow-up risk keeps appearing there, do not stop at the missed task. Look closer. Inspect the sequence. Inspect the handoff. Inspect the message. Inspect the ownership point. Inspect the closure standard. Then decide what actually needs correction. Do not blame from a distance. Use close-up analysis. Find the failure point. Move with control. Thanks for listening to the briefing.